Yes.
Okay, so thank you for the disclaimer as well. Some of these images are graphic, but they're important for what we call pattern recognition diagnosis in medicine. Once you see certain things that are consistently the same, it helps tremendously in making these diagnoses. And in the case of syphilis, it's also important. So I'll do my best today to talk about this vast, vast topic in about 20 minutes time. So keep that in mind as the presentation is built to really hone in on practical and useful knowledge for syphilis in the community. So we'll talk today about syphilis screening, staging, and treatments. I'm Dr. Luis Medina Garcia, and I'm happy to be here with you today. Next slide, please. All right, so the learning objectives, we're going to go over a brief historical overview of syphilis. We're going to talk briefly about the global epidemiology of the disease. And then we're going to touch on the US burden of the disease. We'll familiarize ourselves with the basic indications for screening for syphilis, how to make the diagnosis both clinically and with laboratory tests. We're going to talk about practical disease staging, the preferred treatments, which is always penicillin, just burn that into your mind. And then the challenge of diagnosing and treating neurosyphilis and ocular syphilis, which is really a subspecialty thing, and what to do for the penicillin allergic patient. I think those points there will make it useful for the community at large and hopefully be helpful. Next slide, please. All right, so a brief historical overview. So we've known about syphilis for hundreds of years, and it probably goes back thousands of years based on historical bone records. The historical aspects of syphilis make for fascinating reading and an endless amount of speculation. You know, so many different stories have been told about where it originated. There's endless debate of whether it was a New World versus an Old World disease. We joke, at least in Mexico, that the Spaniards, when they came to colonize us, they brought us pox viruses and we gave them syphilis. Where it actually started, it's not quite known, but what we do know is that after the Spaniards went back to Europe, there was a huge epidemic of syphilis in the 1500s that affected, the vast majority of the European continent. In 1903, Metchikov launched the era of modern syphilology. Remember that prior to that, we didn't have any, objective science on it. By 1906, Wasserman had developed his complement fixation test using an extract from the liver of a syphilitic stillborn baby. And that was the basis of the current non-treponemal test that we use here, like the RPR. And in 1943, John Mahoney of the United States Public Health Service treated the first syphilis patients with penicillin, the true magic bullet. Just so you get an idea, in the past, people were infected with malaria because the high fevers from malaria actually improved the disease course with syphilis, although it was not curative. So really the magic bullet was penicillin. Next slide, please. So when it comes to global epidemiology, it's helpful to remember that syphilis is a chronic, multi-stage, sexually transmitted disease caused by the spirochete Treponema pallidum, subspecies pallidum for the nerds here. According to the WHO, about 11 million new cases of venereal syphilis occur globally each year, and that's obviously those that are properly diagnosed and reported. Globally, about 1.5 million pregnant women are estimated to be infected each year. Approximately 1/3 of these infections will result in stillbirths or other adverse outcomes of pregnancy. Now, this is looking at the global scourge of this, but this happens in Nevada as well. As we will see in further slides, we have the highest level of neonatal syphilis in the country. In developing countries, transmission is largely heterosexual, while transmission among men who have sex with men predominates in industrialized nations. Genital ulcers caused by syphilis are a major cofactor in the bidirectional transmission of HIV. And so this is something that we've known for years. And it's another important part of screening populations at higher risk, because it does increase the chances that you can transmit HIV. Next slide. And so in the United States, the following slides are all taken from CDC. You can see that circa 1941, the total amount of cases of syphilis was really at its highest point almost to 450 cases per 100,000 population. And as the decades progressed, you saw a significant decrease in the total amount of cases, which likely had to do with education about it, as well as effective treatment with the advent of penicillin. You come down to the 2020s and you do see a slight uptick in the amount of cases, which of course is multifactorial. Next slide. So this is a map of the United States and its territories, and the darker the blue color, the higher the amount of disease per state. As you can see, Nevada has 24.9 cases per 100,000 inhabitants, which is the highest in the nation, closely followed by Alaska at 24.1. And the next slide I want you to pay attention to, because it is an action slide, and you could see the color changes through the decades, and it really takes a telling picture of how the incidence of the disease has significantly increased. Next slide, please. And so you can see from 2011, you start seeing darker shades of blue in the map, Nevada included. And it's important to mention that it's not directly related to the total amount of population. For example, New York has a significantly higher amount of people per capita than we do, but still we have a higher incidence of the disease. And the same is true for California and other highly populated states. And that, again, is multifactorial, including the sex trade in Nevada and many other different problems. Next slide, please. So screening. This is, I think, one of the slides that will be most helpful to people. In infectious diseases and in sexually transmitted diseases specifically, one of the barriers is that the clinician is sometimes embarrassed to ask the patient about risky sexual behaviors because of how they may perceive the question. And what I tell the residents that I train here is, look, this is a standard run-of-the-mill question. Preface it that way, to say, I'm going to ask you some perhaps difficult questions for people. I want you to know that I ask all of my patients these questions so that they don't feel judged, right? This is just a standard question. And so the idea of it is to identify the level of risk so that you can screen properly and treat at a timely fashion. So in women and men who have sex with women, you are to screen asymptomatic adults at increased risk, such as those with a history of incarceration or transactional sex work. Depending on where they live, race and ethnicity plays a role into this, as well as being young. Pregnant women should all be screened for syphilis in the first prenatal visit. Hopefully that will be very early in their pregnancy. And in patients at 28 weeks gestation and at delivery, if at high risk, who live in a community that has high syphilis morbidity, you should test them again to make sure that if they are infected, they get timely treatment to prevent issues with the baby. In men who have sex with men, the recommendations are to test at least annually in those that are sexually active, or every 3 to 6 months if they are believed to be at increased risk due to sexual behaviors. In the transgender and gender diverse population, it really just tells you, look, based on the sexual behaviors that they report is how often you should test. And in persons with HIV that are sexually active, you have to screen them at least at the first HIV evaluation and then annually thereafter. But if they do report high risk sexual behaviors, then more frequent screening is appropriate. Next slide. So syphilis is increasing in the United States, but it is 100% preventable with education. In early 2021 data show an increase in primary and secondary syphilis among adults. Women are more affected than men, 34% versus 9%. And if patients are sexually active, they should be educated to ask questions to their medical providers as to how to prevent these sexually transmitted infections in themselves, as well as how to protect their partners. And getting tested and treated really has a very important part in this. Syphilis in newborns, which is pretty tragic, is up 6% in 2021 with 2,268 cases already reported. And 33% of states report an increase in cases. Now, this is really, really important because once the baby is born with syphilis, and they have damage because of it, you really can't fix that. So the whole idea of it is preventing the mother from getting syphilis infection. If she does get syphilis infection, treat them in a timely manner to prevent damages to the baby. Next slide.
Dr. Medina, if we can pause this for 1 second, there are a couple of questions in the chat box that I'd like to get to. So Cheryl Radeloff asks, do screening recommendations align with SB 211 and AB 192?
I need a little bit more context in those Senate bills.
Cheryl, if you can unmute and share a little bit more information if you have it.
Sure, can you all hear me?
Yep,
Yeah.
Go ahead, please.
Okay, so SB 211 was just passed, and it asked all providers to ask folks 15 and over if they'd like to be tested for HIV and STIs. And then if they do, then they proceed. I think there's some exceptions with emergency rooms. And then AB 192 added to prenatal screening, including gonorrhea, chlamydia.
So these recommendations that we talked about are national recommendations from CDC. Statewide, I'm not 100% familiar with the indications on the Senate bills, but I would tell people offer testing as often and as frequently as possible that the patient agrees to testing. And that is a high impact intervention. If you look at what we did with HIV with opt-out testing, which means everybody that comes to the ED that gets blood drawn at UMC will get an HIV test unless they opt out. And we have increased our diagnoses of HIV in people that otherwise would not have been tested. Now, the importance of that is you can get them into care earlier and you improve outcomes by starting antiretroviral therapy as well as preventing the spread of the disease. So I just tell people if somebody is at risk, offer testing, even if they're not at significantly higher risk than others. It's never a bad idea to just offer testing to people. I don't know if that answered the question. I hope that helped. And then the next question was from Dr. Levy. How does Nevada geography and current prevalence affect how you screen for syphilis in those that report themselves to be heterosexual? I don't exactly know the rest of the Nevada impact on syphilis. I know that for sure Clark County has a very high incidence of it. And I make a corollary with what HIV recommendations for testing are, is everyone should be tested at least once for HIV in their lifetime. If you're above the age of 13, or I think it's up to like age 64 or 70. And if you're going to offer HIV testing, it is definitely reasonable to offer testing for other sexually transmitted diseases, including syphilis. And especially for syphilis, treponemal testing remains persistently positive pretty much for the lifetime of the patient. So if they've never known to have syphilis, that doesn't mean that they haven't had it in the past. So there's a role for testing there, and we'll talk about that a little bit more in depth with the case and later on in the presentation. Any other questions we want to address before we move on?
Yeah, any other questions, feel free to unmute yourselves if you do have one, please, or use that chat box. All right, moving on.
All right, this is the graphic pictures that we're going to talk about. Now, when it comes to diagnosis of syphilis, there's really two main ways to make the diagnosis. The clinical diagnosis, which is cheap, quick, and fairly specific, and then laboratory diagnosis. So we're going to start with clinical diagnosis, which is what you can see. Now, the case that will be presented a little bit later on has a patient that had oral lesions that ended up having syphilis. And so this is usually how syphilitic chancres in the mouth look like. On the left-hand side, you see those 3 lesions at the base of the tongue. Now, these are very nonspecific. And in a patient who has a history of other sexually transmitted diseases of viral nature that also cause oral ulcers, it's easy to be distracted and say, well, they have a history of that and not think of syphilis. But this is why, you always have to have syphilis in the back of your mind. When I was in training, my attendant used to say, look, if you're on rounds and you get pushed against the wall and say, what disease can do X, Y, and Z? If you answer syphilis, tuberculosis, or HIV, they have to leave you alone because they can do anything. So always have those 3 diagnoses in the back of your mind. And so oral lesions due to syphilis, another reason why infectious disease doctors are obsessed with looking at people's mouths, right? When we talked about endocarditis last time, we really made an impact on why it was so important to look at the dentition. In the case of syphilis, you can have oral chancres. The penile chancre, which is what you see here, is a classic presentation, and that's diagnostic, right? If you see a chancre like this and it's not painful, you can pretty much make the diagnosis of syphilis without any further testing, and then treat this patient with primary syphilis. And then on the right-hand side, you have a lesion in the right commissure of the lips that can easily be confused with a cold sore due to a viral nature. But if you ask the right questions and the patient is at risk, then you can understand that this is a syphilitic chancre and that you can just treat this patient without further testing and call it a day. Next slide, please. And so this is a genital lesion on the left in a woman who has vulvar lesions that are hypopigmented, and they look like venereal warts. And so this is what we call condyloma lata, which can be confused with genital warts. But this is a manifestation of syphilis that needs to be, burned in people's minds. When they see it, think syphilis right away, treat, and then you can test for confirmation later on, but really you should treat people. And on the right-hand side is the rash, the diffuse rash of secondary syphilis. Now, this is important for people also to look at because you see rashes all the time. And I mean, even as a clinician myself, whenever I've had a rash, I start thinking of, oh, well, what did I eat? Did I take a new medication? Did I have a contact with new plants or new animals or something that could explain the rash? And this rash can then go away after a few days. And if one doesn't stop to think and ask of sexual behavior questions in our history and physical, many cases of syphilis, of secondary syphilis, are missed because of it. And so a quick and easy way to remind yourself when to think of syphilis right off the bat is when you see a similar rash like the one you see in the picture, but that also involves the palms of the hand and the soles of the feet. And some lesions, you guys can Google these pictures later, where they mention them as copper penny rashes. And that's very, very characteristic of syphilis. And you'll always be pointed towards the right diagnosis if you think about that. Next slide, please. Now we're briefly going to talk about laboratory diagnosis of syphilis. There are many different tests that you can get, but this is a way that we simplified it. The left-hand side has a figure that shows you the traditional screening algorithm, which used a non-treponemal test like VDRL or RPR to screen patients. If that test was negative, we would have said this patient doesn't have syphilis, or if they have syphilis, is very early in the infectious stage so that you don't have an antibody response to it. And if it was positive, we just said, okay, well, the patient has syphilis. You have a confirmatory test with a treponemal test. And if that confirmatory test was positive, you said that this patient had syphilis. And if it was negative, you essentially said they didn't have syphilis. Why is that? Well, because there are some conditions that can cause you to have a false positive syphilis test on the non-treponemal side. And so circa 2010, 2015, the CDC asked us to do a reverse screening algorithm. So on the left, you note that you have a non-treponemal test first, and then you get a treponemal test to confirm. And so what they found out was that there were many cases of syphilis that were missed because the non-treponemal test was initially negative. And so that can happen in non-treponemal tests. As time goes by, those antibodies come down and then they're non-detectable. But if you look at treponemal testing like EIA, FDA antibodies, or TBVA, those maintain the positive level over the course of several decades. So the thought process was, all right, well, if non-treponemal tests wane and then they become negative, let's check for the one that is always positive first and then work our way down. So if we go down this algorithm, the screening part starts with a treponemal test. And if it's positive, then you do a non-treponemal test to confirm. If it is reactive, the thought process is you have syphilis and you acquired it fairly recently. And if it's negative, you check a different treponemal test. If it's positive, then you treat it as syphilis. And if it's negative, you say, look, you may have had a false positive treponemal test of a different nature. That's why the second treponemal test in this algorithm on the right uses a different treponemal test than the initial one for screening, if that makes any sense. And so the idea with this is identify those patients that have had syphilis before, that have a positive treponemal test, but that in their non-treponemal test, those levels have waned, and that's why they're not positive. And so it helps us pick up some cases that would otherwise go undiagnosed. And I'll pause here in case any one of you have any questions or comments about this, because it's a lot of information to process.
I do see one comment in chat that I'll just mention quickly, and thank you to Cheryl. She dropped the Senate Bill 211 toolkit developed by the Nevada AETC for resources for HIV STI testing link in the chat box.
Thank you so much. I'll take a look at that to be better informed too.
Thank you.
All right, so let's move on to the next slide in the interest of time. And so this is a visual representation of those antibody levels and why sometimes if you test too early, like in primary cases of infection, you may have a negative treponemal test. And so as you can see, the longer it takes, so in the primary section, you have about 2 to 3 weeks. In the secondary syphilis stage, you have about 4 weeks to a year. And when you come to latent disease, it's 1 year to 10 years, and then tertiary disease is usually 10 years plus. So if you look at the non-treponemal testing, after about 2 years, you know, the vast majority of patients will have a waning in those antibody levels, and they may be negative. This is why, and the treponemal IgG remains elevated for decades to come. And that's why sometimes you can have a negative non-treponemal test in early disease, or why you could miss patients with syphilis with non-treponemal tests. Next slide, please. So how to stage the disease in a way that is simple and useful. And I found this graphic on the internet, and I used it because I thought it was really representative in a simple fashion of how to do it. So you have infection with Treponema pallidum, and that causes primary syphilis, namely the syphilitic chancre, be it in the genitals or the mouth. You know, one of the challenging ways of presentation is rectal syphilis, because you really can't see the rectal vault unless you do an anoscopy, and the vast majority of people don't do that. And since the ulcer is painless, the patient doesn't have any symptoms of rectal discomfort initially. They can develop proctitis later, but we're not going to get into that. So secondary syphilis is usually when you have skin disease like the rash that we saw. There's also involvement of the kidneys sometimes, nephritis, et cetera, in secondary disease. But that's a little bit more nuanced and difficult outside of the scope of this talk. And then you come to latent syphilis, which is divided into early latent and late latent, and we'll talk about that in the treatment section. Early latent is within 1 year of seroconversion. And so how would you classify that as early? Say you talk to the patient and you ask them about any genital lesions. Oh yeah, I had a lesion on my penis that was painless, and then it went away. And if that time frame fits within that first year, you categorize them as early latent syphilis. And if it is after 1 year where they had reported a lesion, or if they don't have a recollection of the time frame when that happened, you just categorize them into the late latent stage. And that is important because it has treatment implications. And we'll talk about that in the next slide. And then the third the last stage of it is tertiary syphilis, which is usually presenting after a long period of having otherwise clinically undiagnosed disease. And that's where you can run into trouble with bone disease, skin disease, CNS lesions like gamma, cardiac involvement, etc., etc. Now, as a separate part on the right-hand side of the graphic is neurosyphilis, ocular syphilis, or otosyphilis, which is essentially central nervous system involvement of it. And this can occur at any stage. Now, I mentioned this separately because it is a very difficult diagnosis to make, both clinically and with laboratory information. I have to, give props to the Southern Nevada Health District here, because they send us a lot of patients with suspicion for neurosyphilis. And, every time I get a referral from them, I take it very seriously. Every one of them gets tapped. And I'd say that at least, 50% of the time they were right. And for the other 50%, some of them also still have neurosyphilis. And so the reason why I bring it such a difficult diagnosis, which is because the test to confirm neurosyphilis is the VDRL in the cerebrospinal fluid. And in patients with neurosyphilis, that test is only positive in 50% of cases. So the sensitivity is very low, even though the specificity is very high. So in someone who has an infection with syphilis that has any neurologic finds on exam, it is entirely reasonable to send them for lumbar puncture to look at the protein, the glucose, the cell count, and the VDRL. And so if that VDRL in the CSF is negative, but the rest of the CSF studies look suspicious, like hyperproteinuria or high white cells, then my recommendation is uniformly to treat them for neurosyphilis, because the consequences of not treating neurosyphilis appropriately are really dire. All right, next slide, please.
Real quick, Dr. Medina, we just have 2 quick chat messages. I thought this might be a good place. So Dr. Montalvo Stanton said, have you seen any pulmonary manifestations with syphilis nodules?
So there are reported, I have not seen them personally in my practice because it's so very difficult to prove that. Most of the cases of syphilis that we see are primary or secondary in nature. And usually by the time that we look into evaluation of pulmonary nodules, at least in this part of the United States, is either tuberculosis or coccidioidomycosis. So I haven't personally in my practice identified people with syphilitic nodules in the lung. Although, like I said, it could do anything, just like HIV and tuberculosis. And then the next one was, is it possible to develop neurosyphilis after treatment? And so the answer is yes, especially if you have incomplete treatment, right? So when we move over to the treatment section, if you treat someone who actually has latent disease and you treat them as early latent, then you have incomplete treatment. And so then that can progress later on because of incomplete treatment. If you choose, for example, the wrong type of penicillin, i.e. not the long-acting benzathine penicillin, then the concentration of penicillin is not high enough to kill the way it should kill, and then you can have incomplete treatment and then recrudescence of disease in the absence of subsequent exposure, if that makes sense. So yes, you can. It's usually because of a treatment that is too short, or the pharmacodynamics of choosing the wrong type of penicillin to treat, and that resulting in treatment failure. But uniformly, penicillin is the best drug to use for this. We just got to get the right type of penicillin to administer, and then for the right duration.
Great.
All right.
Thank you, Dr. Medina. And we have about 4 or 5 more minutes left before we have to move on to the case. So I'm going to go ahead and move to your next slide if we can.
Yes, let's speed through this. So treatment, you divide it by stage. Primary, you have benzathine penicillin LA, which is the long-acting, and you give 2.4 million units intramuscularly times 1. For secondary syphilis, i.e. skin disease and sometimes kidney disease, it is the same treatment as primary disease. Now, when we get to the latent part, this is where it was really important to differentiate the duration of symptoms from the lesion, because if it is less than 1 year of duration of the symptoms, you treat with 1 dose of penicillin intramuscular. So primary, secondary, and early latent disease are treated with 1 dose of intramuscular benzathine penicillin, long-acting, 2.4 million units times 1. But when you get to late latent, which is more than 1 year from the onset of symptoms or an unknown duration from the initial diagnosis of syphilis that is without treatment, then you have to give 1 weekly injection for 3 doses. So essentially 21 days. Now, with the LA formulation of benzathine penicillin, you get about 7 days worth of coverage of antibiotics. So late latent disease, you get 3 shots, 1 shot per week for a total duration, effective treatment duration of 21 days. And for tertiary syphilis, the same is true, right? You need 3 shots once a week of 2.4 million units. But the caveat here, and this is important to mention, is that you should investigate the CSF, the spinal fluid, through a lumbar puncture to rule out the presence of neurosyphilis, of neurologic involvement. The reason why this is very important is because if you do have neurosyphilis, the benzathine penicillin formulation will be insufficient for treatment. You need IV penicillin to treat neurosyphilis. Okay, next slide. So we briefly touched on why it's difficult to make the diagnosis of neurosyphilis. Long story short, somebody with evidence of syphilis infection and any neurologic manifestation, Bell's palsy, headaches that are relentless, disequilibrium, if you have difficulty with walking, you feel dizzy, whatever it is that is weird, new onset hearing loss, any visual changes, you are to refer these patients immediately for further evaluation, check the CSF, and treat them appropriately. So if you have neurosyphilis, the treatment is with intravenous aqueous crystalline penicillin G. Very important to choose the right type of penicillin for the right type of stage treatment in syphilis. And you give that, my preference is 24 million units a day via continuous infusion pump, because that way you don't have to worry about giving it every 4 hours. And your nurses love you for doing that instead of having to give a medicine every 4 hours. And it ensures compliance, right? You put this pump on the patient once a day, every day for 10 to 14 days. Depending on how severe the neurologic involvement is, I usually go for the full 14-day course. In some instances, we can do 10 days. The alternative, although not preferred, is to treat with procaine penicillin G intramuscularly plus probenecid. And so the probenecid actually impairs the metabolism of penicillin so that you have maintained levels of penicillin that are going to be therapeutic. But that is really not my preference. Somebody who has neurosyphilis, really, you should go through the extra trouble of hospitalizing them and just treating them appropriately. Next slide, please. And when it comes to penicillin allergy, this is super important because the vast amount of penicillin allergies are not true allergies. Somebody was told at some point in their life that they were allergic to penicillin. That follows them forever. And it really robs people of the standard of care and the most effective treatment option in syphilis infection, which is penicillin. So only about 5 to 10% of those penicillin allergies are true allergies. Whenever you encounter a patient with syphilis, especially neurosyphilis, that has a penicillin allergy reported, I always ask him if it was if you had difficulty breathing or hives or anaphylactic in nature. And then, if it's neurosyphilis, my preference is to desensitize them in the ICU and treat them with penicillin. But if this is not, tertiary disease or neurosyphilis, you can treat them with alternative drugs. Doxycycline, 100 milligrams by mouth every 12 hours for 14 days is the standard, or tetracycline, 500 milligrams PO every 6 hours for 14 days. Tetracycline is usually not preferred because it has a lot of GI side effects and is poorly tolerated as compared with doxycycline, but that could also cause GI side effects and other problems like photosensitivity. And then alternatively, you can treat these patients with ceftriaxone, either intravenously or intramuscularly, 1 or 2 grams a day for 10 to 14 days. And as an option of last resort, say in somebody who is definitely penicillin allergic, there is cross-reactivity with cephalosporins like ceftriaxone, third generation cephalosporins with true penicillin allergies, you can give them 2 grams of azithromycin times 1. But honestly, this is not good practice. If you have to, you do it, and then make sure that 6 to 8 weeks later, you repeat the RPR to make sure that you have a cure. That's the other part that we didn't mention here, but that should be borne in mind, is that once you have that initial titer of that non-treponemal test like the VDRL, look at that titer. You want a 4-fold decrease in those titers to consider the patient cured. All right, next slide.
Dr. Medina, just we are running quite a bit short on time, so well, is this your last one? You're just going to summarize learning objectives and we're done? Okay. Just
to remind you,
sorry.
Objectives is what we talked about, and invite anybody to ask any questions should they have any. And thank you for your attention. This is a fascinating subject, a passion subject for me to teach, but there's so much to know, so much to tell, so many stories. But I wanted to make this presentation useful for people out in the field, so that diagnosis and management becomes easier for all.